Thank you, everyone. Good morning. Yes, Carrie and I are presenting this together because this has really been a collaboration. So we're really excited to present our collaboration between Genomic Medicine Service and West Palm Beach VA. Which button do I push this one? Okay, so we have no disclosures. So what I'd like to first do is talk a little bit about genetics. Genetics is exploding. Over the last 20 years, our knowledge of genetics has really expanded, and there's a real push basically to incorporate genetics in both primary care and really standard of care for a lot of diseases. So as you can see from this chart, we've gone from knowing the genes for less than 10 germline conditions to almost 3,000, and I'm sure by now it's over 3,000. To talk specifically about sort of how does genetics play a role in oncology, the role of genetics in oncology is probably close to that 20-year mark as well, but the number of conditions in oncology that we know about are much more limited. However, as most of you know, there are many guidelines that suggest that genetics should be a routine part of treatment and evaluation in the oncology clinic. Clearly, most people are familiar with NCCN guidelines as far as when to do evaluation for underlying inherited genetic cancer predisposition syndromes. Everyone's familiar with ACS Standard 2.3, the need for the availability of genetic evaluation at your center, and as well as the preventative task force recommendations in regard to BRCA evaluation specifically. And of course, most of you are also familiar with genetics because the company representatives come to your office. Myriad, of course, was very active marketing and BRCA testing. As of June, when the patent was dissolved, of course, the marketing has become even more aggressive, I think, from more offices. So there are numerous companies now offering genetic testing in cancer and specifically BRCA testing. And of course, the media has been abuzz with genetics this summer. There was the patent, the Supreme Court decision, and of course then there was Angelina Jolie coming out discussing her BRCA status, which again just brings genetics sort of to the forefront of national media, which brings patients in asking about genetics and how to receive these services. So I want to talk a little bit about how the VA has been addressing access to genetic counseling. And I'm breaking it up, the difference between genetic counseling and genetic testing. So specifically talking about counseling, how are patients getting genetic counseling? I think in a lot of places, genetic counseling is still provided by non-VA care coordination, which is really location driven. And I'm going to talk a little bit about genomic medicine services later, but when we came on, we're a national department, basically, and we've really been talking to VAs across the country, and how people handle access to genetic counseling is so location-driven. It really depends on what kind of relationship you have with the outside source of genetic counseling, how close that is, how far do patients have to drive, how long is the wait time. So it's really variable how people are getting, even their non-VA care coordination, genetic counseling. The other problem in the VA is that for some patients, they're just plain not getting genetic counseling. Providers don't think that there's service available anywhere. They don't, if the only option is outside of the VA, again, veterans are unlikely to travel long distances to receive that care, so there are a lot of places where genetic counseling just plain isn't being provided. The other way that patients are getting genetic counseling is from current providers within the VA. Now, these are not genetic counselors per se, but other physicians and trained nurses would be providing the genetic counseling. The limitation, of course, is that some providers are much more knowledgeable and more able to provide this service, and others are less comfortable with this role in their job. So then to talk a little bit about the genetic testing process itself, which I think it's a very different process. The counseling is a face-to-face consult, where testing in many cases is, quote, just a blood draw. So again, how are patients getting genetic testing? Number one, they can still be referred out for non-VA care coordination. The limitation, of course, is that we have no control over who gets tested and who doesn't when this happens. We're relying on our outside provider, which again, in some places, if you have a great relationship with that outside provider, then you may be getting really good quality care. But in other places, we don't really have any control over that. The other issue with the non-VA care is actually inflated pricing of genetic testing. So, as most of you know, genetic testing is incredibly expensive, and, well, not in comparison to, I guess, the drugs, but from a lab test perspective, genetic testing is really expensive. So many people are really uncomfortable with that cost. And then when you add it into a non-VA care coordination, oftentimes you'll get an inflated price because the genetic testing is bundled. So sometimes the VA is charged double the cost of the test, if not triple the cost of the test. And again, in some places, people plain just are not getting genetic testing. Even though it's appropriate, they may not be getting tested through their local facility because, again, it's an issue of the pathologist not knowing where to send it, how to send it, the cost, that sort of thing. So there are patients that should be receiving this service that aren't. And again, in some places, there are current providers who are ordering genetic tests. But again, we have the limitation of some providers are much more comfortable with that than others. There was actually a review of CPRS and whether or not informed consent was documented. There is a rule in the VA that germline genetic testing needs to have documented informed consent in the chart. And when they did a review of charts, they found that this was lacking in many, many cases. The other issue is test coordination. In many sites, we're talking with pathology and send-outs, and they just plain don't know where to send these tests. BRCA testing was a little bit easier about 6 months ago because there was only one lab, so that wasn't really complicated. Although there was only one lab, so then oftentimes it had to go through contracting. And everybody knows how people feel about contracting in the VA. So what I'm going to talk about today a little bit is really how West Palm Beach VA was handling their genetic testing and counseling, and specifically for BRCA. So West Palm Beach VA was using non-VA care coordination and referral to community clinic for the actual consult process. So a patient would go out and have the consult, and then that provider would have their recommendations, and if testing was recommended, then that was done at the VA. And of course, at that time, there was only the one company, Myriad, that was offering the testing, which they didn't have a contract for. The cost of the testing was approximately $4,000. So, about 8 months ago now, we entered into agreement with West Palm Beach Genomic Medicine Service. For those of you that are not familiar with our service, Genomic Medicine Service, our goal is really to equalize access to genetic counseling and diagnostic testing for our veterans across the country. Like I said, we are a national clinic service, and this is important. We are a clinical service. We are not a research service. We are a clinical service, and we provide genetic counseling through the telehealth infrastructure. So we see all of our patients through telehealth, and we are field stationed Salt Lake City, but we see everybody kind of across the country. Currently, we are up and running and seeing patients in 41 sites, and we are growing rapidly. So the West Palm Beach Genomic Medicine Service collaboration began in February of 2013. On average, we're receiving about 7 referrals a month. Our main source of referral, and this is true across the board, is really from women veterans healthcare and primary care. So those are the majority of our referrals. In West Palm Beach, we actually haven't received any from hematology oncology, but I think part of that is also in the system, you know, if people really refer back to primary care, to refer back out to specialty care. So we've seen a lot of patients for heme-onc concerns, just not directly from hematology oncology. So now, Carrie is going to talk about sort of our outcome data.
Thank you.
Great, thank you. So we're going to briefly just go over our outcomes, and those weren't really defined with regard to a telehealth genetic testing program, so we tried to identify what we thought would be important that track the quality and the timeliness of care. So essentially we looked for presence of consult notes if they were completed, if there was testing offered, completed, if they had a follow-up visit for counseling after testing was performed, and was the actual BRCA result present in CPRS. With regard to the timeliness of documentation, we wanted to make sure that just the initial report was scanned in NCPRS. And again, was the BRCA test result, even though it was completed, was that scanned and entered into CPRS? And then the follow-up visit, again, was how long did it take for that information to get there? And then finally, the cost effectiveness. What is our cost per consult? So just with regard to the consult documentation, and you see the NVCC column is the patients that were referred out prior to our contract with genomic service, and the SLC GMS is after. And what's interesting is that NVCC time frame is really 3 years. So just within 3 years, we referred out about 35 women, and in the last 8 months, we've referred 37. So I think that just goes to speak to the education and access that we've provided to the facility. So you can see with the amount of completion for NVCC care, 77% were completed versus 100% with genomic medicine. When we referred out to the community, 100% of the women were offered testing. Through Salt Lake City GMS with appropriate counseling and referrals, 8% are offered testing. Follow-up visit after testing, 55% received, had documentation that they had a follow-up visit with GMS 100, and BRCA result in CPRS. We only had that official lab result in 63% of the patients versus 100 because we're doing it at our site. So just if you look at timeliness of documentation, the blue line is the non-VA care and the red line is genomic medicine service, and those are the mean time in days. So you could see we dramatically reduced the timeliness of documentation in the electronic health record, which, as we all know, has implications for treatment and management. And finally, cost effectiveness, our final cost per consult. And actually towards the end of our period when we were referring out, we were drawing labs at West Palm, but for a long time we couldn't get a contract with Myriad, so even the BRCA testing was done outside of the facility. So our average cost per consult was over $7,000 when we went through non-VA care, but once we reached our agreement with genomic medicine, you can see it's reduced to $188 a consult. So while Becky and I are here to share with you our partnership, it couldn't have occurred really without telehealth and a strong telehealth program. So I would say to reach out at your facility if you don't have this in place, to make sure that telehealth is involved and engaged and that you really have a champion at your facility to help move things along. We found that the care for our veterans is better. They have access to local care, not just at West Palm Beach VA, but between the video teleconferencing, they can even be seen at a CBOC and scheduled for genomic counseling. It decreases dual user, fractionated care, getting the labs here, getting your counseling here, going back and getting your results. So it's much more smoother process at West Palm. And I think with regard to shared decision making and informed consent, I really feel that we're providing a quality service to our women and our men to make sure that they're getting the information that is needed to make sure that they feel comfortable with the testing and the results that they're going to receive. This is better for providers because the information is there. It's readily available, the turnaround time is short, and as you can see by the referrals numbers, our providers are very engaged in this and utilizing the service. And finally, it's better for the system. There's less cost both for consults and testing. What we didn't include in the cost was a lot of when we referred out, many times they were referred to other specialists, referred for additional genetic testing. Those were costs that we didn't even include in that initial cost analysis. So really when we send we sent them outside of the VA for their care, the quality of care wasn't really monitored. We weren't in control of that or of the cost. So that's something to really think about when you want to have a manageable program where we know the quality of care is good. So I thank you for your time, and Becky and I will answer whatever questions you have.